So hi, I'm Katie, Katie Stonall. I'm a lived experience practitioner in the mental health liaison team.
And I'm Jo Tym, and I'm a lived experience practitioner in the complex emotional needs service.
So we are here to talk about lived experience and peer support. So Jo, can I start by asking you, what is peer support in its widest sense?
So peer support generally is the concept of kind of working side by side with the patient and the professional. So you work on a peer-to-peer level. So it's not a traditional kind of sort of clinician/professional hierarchical relationship. It's a relationship where you work together. You use a lot of mutuality and reciprocity to work kind of together to share experiences. So the peer support worker will share experiences from their journey through their health journey, and that will kind of hopefully benefit and give a bit of hope to the person who's going through it currently, because they can see somebody's kind of gone through it and come out the other side. So peer support is kind of using that experience to generate hope and optimism in the patients that are being kind of peer supported.
You use two words that we use a lot in peer support that other people might not be familiar with in this context. So you talked about mutuality and reciprocity. Could you just explain a little bit more what that means?
So basically, mutuality and reciprocity is the kind of values that peer support workers work towards. So it's sort of standing on an equal footing with the person they're supporting and having that completely balanced relationship. So like I said, there's no hierarchy involved. It's kind of like a peer-to-peer relationship rather than sort of somebody's got more experience than you. It's kind of using both people's experiences together.
Yeah, and the reciprocity, I always feel I learn from people, they
Absolutely.
learn from me, and it's not I'm telling you what to do, it's let's work out together what will be right for you.
Yeah, completely.
So tell me a little bit about what it means to be a lived experience practitioner.
So being a lived experience practitioner involves peer support work. So I do one-to-one peer support sessions with some of my clients, but also I do a lot of going to multidisciplinary team meetings and potentially chairing meetings. I help facilitate and design a lot of training. I help on sort of projects throughout the trust as well. So it's a lot of different jobs, but it brings a great variety to my day-to-day life, which is really, really interesting. So, yeah.
So I often get asked what's the difference between a peer support worker and a lived experience practitioner. And I think the core element of the job is exactly the same. We support people using our lived experience. But then as a lived experience practitioner, we do those extra tasks like the training and the maybe multidisciplinary meetings and projects that wouldn't necessarily be expected of a peer support worker. So if a peer support worker or a lived experience practitioner is supporting an individual, you're essentially going to be getting the same thing. It's just the other things that we do above and beyond that make our job slightly different.
Yeah, definitely. So is peer support just for mental health? Is that kind of just a mental health thing, or does it expand to kind of other services as well?
So peer support very much started in mental health. But I think the values and the benefits have been recognised, so it's now extended into physical health as well. So we have colleagues who work in the Health and Wellbeing College who will support people with a long-term physical health condition as well. Mm-hmm. Across the trust, at the moment, I think we have about 17 peer support workers and lived experience practitioners, and I've written down the teams they work in just so I don't forget anybody. So we have people in the Health and Wellbeing College, people in the perinatal team, people in complex emotional needs, yourself, Jo. There's somebody who works in employment services, eating disorders. I think we've got 3 in crisis teams, and then there's me in mental health liaison.
Fantastic. So it's quite a broad spectrum now, but getting broader, hopefully.
Yes, and I think the trust is at an early stage. So there's lots of scope for development. So we're hoping that you'll start to see lived experience practitioners and peer support workers popping up in other teams as well.
We can take over the world.
Yeah. So this is a bit of a tough question, Jo, but what is an average day like as a lived experience practitioner in the complex emotional needs team?
Oh, gosh. I'd like to say there is no average day, but I'll kind of put together some parts of my week and make it into an average day. But basically, I might start in the morning going through emails, checking what emails I've got regarding reflective practices or multidisciplinary meetings that I have to attend, those kinds of things, getting back to people, getting back to care coordinators. That's something that I do quite a lot because we work quite closely with care coordinators in the complex emotional needs service. And then I might have a one-to-one peer support session with somebody, which usually I do in a coffee shop or somewhere like that, just to put people at ease and have a drink whilst we're doing that, which makes it a little bit more relaxed. Then I might come back and have a training session in the afternoon, by which I mean I'm facilitating training. We do a lot of bespoke training for different teams, both across the trust but also in the voluntary care sector. So I might do some of that. At the moment we're doing some fire service training, so that's kind of quite current. Then I would come back in the afternoon, hopefully grab a bit of lunch in between, and come back in the afternoon and perhaps prepare for a reflective practice session, which I would help facilitate the next day. So it's quite varied, but I really love the variety of my job. It's great.
I was really intrigued by the fire service training. What is the nature of the training that you're doing with them?
So we're doing training basically in terms of the sort of call handling people who might get called out, and the fire service who might get called out to help the police when they get called to people who might need a welfare check or something similar, and the fire service often get called along. Or, for instance, in the complex emotional needs service, we deal with people who are quite often feeling suicidal, and often find people, for example, who go to bridges and then the traffic has to be stopped and the fire service have to come and all that kind of thing. So we're training the fire service in how to best experience people with complex emotional needs, and the best kind of top tips and how to keep calm in those situations and help the people who they're trying to support.
So would you be using then your own experience of situations and what you've learned from people that you've supported?
Absolutely. So yeah, I can use my own personal experience, but as with everything regarding peer support and lived experience, I can only give my own personal view, but by collecting the views of the people who I work with, I can also pass on kind of more general opinions on what happens in these situations and what's best practice and how to help manage them, really.
Because I've noticed people will often tell me what they like or don't like about services.
Absolutely.
And I tend to sort of gather that repository of information so that as and when it's needed, I can say, well, these are things that have worked well, these are things that haven't worked well. So I'm not just relying on my own experiences, which would be just limited to one person.
Exactly. We can kind of be the middleman, which is quite useful at times.
It's interesting what people will tell us.
Yes.
That they might not have told a clinician necessarily.
Yeah, definitely. So how about you? How does a typical day look in the mental health liaison team?
So I suppose compared to my colleagues who are working in the emergency department all the time, my day's a little bit more structured. But my day's still very much responding to what's going on at the time. So I might have a really wonderful plan of what I'm going to do. And then I might be asked to do something slightly different. In terms of a usual day, I attend morning briefing, so I know who's in the hospital, on the wards, who's in the emergency department, and I have an opportunity to speak up and say, well, that might be something I could contribute to. Then I will often go and visit people on the wards, sometimes with a clinician, sometimes by myself. And the way that visit goes is very much dependent on the person. Sometimes it's helping them to spend some time off the ward. Sometimes it's taking them things like colouring books, pencils, pens, helping them to find activities that are going to help pass the time. Sometimes we might look at coping strategies. Coping strategies that work well at home don't always then translate very well into the hospital.
Yeah.
So sometimes we have to be a bit creative and find ways of making that work. And sometimes people just want to talk. So I can sit by somebody's bedside and talk with them. A lot of the time, at the moment, the patients I've been supporting have been patients with an eating disorder.
Mm-hmm.
And one of the things that I also do with them is care planning. So they will talk to me about language they want people to use or approaches that have worked well for them. And I can then bring that together into a care plan for them so that everyone that's supporting them will have that information. I think that can be really helpful to just reduce the likelihood of things going wrong.
Fantastic, yeah.
Afternoons are normally spent phoning patients. So those would be patients that have been either discharged from the wards or discharged from the emergency department. And we try and anyone who's not being discharged to a team in the community, we try and give them a call just to see how are things going. If they were asked to contact their GP or to make a self-referral, then I'll just work out with them, have they managed to do that? And if they haven't, we might look at some of the barriers that they need support with. And again, for some people, it's just having somebody to talk to. At the moment, I can make up to 4 calls after somebody's been discharged from the emergency department, and we agree between ourselves how quickly they want those calls to take place, what kind of gap they want between the calls, what they want the calls to be for. So it's really lovely that I get to be really responsive to what that person needs rather than having a very strict kind of plan to follow.
Yeah, so like person-centred care is very, very central to what you do, which is really important. And I think also what you said about the use of language, particularly with those patients who you're working with on the wards, I think use of language is really important across what we do as peer support workers and lived experience practitioners in terms of helping clinicians and other professionals see that perhaps there has been a change in the use of language since when they trained, and actually perhaps things are slightly different now to how when they kind of were used to working with patients previously.
Yeah.
And I think that makes a huge difference to things like stigma and just general treatment. And I can imagine that's particularly important in the hospital environment as well.
Yeah, I think particularly with staff who aren't used to working with patients who have a mental health problem, sometimes it can feel a little bit overwhelming. I've had staff asking me, how do I explain this? How do I say this? How do I not offend the individual? And it feels like I'm a safe person to ask.
Yes.
And I can then give sort of feedback on maybe words to avoid or approaches that might not be so helpful.
Yeah.
Another part of my job that we're developing at the moment, because I've only been in post for 9-10 months, is supporting patients whilst they're in the emergency department. So that's something that I'd like to grow, and that would be possibly sitting with someone before or after a mental health assessment, giving them a chance to kind of put their thoughts in order before they speak to one of my colleagues. And we're just working out how that might work. Similarly, if someone's really distressed, but they don't necessarily need any active mental health support, I can take them for a coffee before they go home, just to make sure that they're going home in a safe state of mind.
I think that would make such a difference. I think that's really important. Yeah. Just kind of grounding people before they leave the emergency department, because it can be quite an overstimulating environment as well, can't it? And whilst it's kind of overwhelming for staff who haven't worked with people with mental health issues before, it's also overwhelming for the person with the mental health issues. I think everybody's in a kind of state of overwhelm, and going for coffee or taking them out and just sitting with them or listening to them, like you say, getting their thoughts in order would be really useful.
What we're trying to do is listen to people and what they think would be helpful for them, and then trying to put together sort of like a menu of options, so that if somebody is struggling to know what would help them, we could maybe say, these are some of the things we could do. I'm also involved in service development projects. One that we've recently rolled out is comfort items in the emergency department. If someone's waiting for a while to be seen, we can give them kind of fidget toys or squeezy balls or colouring pens. We've got some eye masks, and that's all come back from feedback from the people that were being supported, that these are things that might have made my journey a little bit easier.
That's fabulous.
So that's something that's quite exciting to see. See patient feedback being then acted on and making a difference. So I think we've given out 18 items so far this month.
Oh, fabulous!
Which is really cool.
Oh, that's really good.
Yeah. So that's an average day.
Very busy.
It is busy, but I really love the variety. And I kind of like not knowing exactly what I'm going to do that day. Yeah,
every day being different is really, it's kind of exciting, isn't it? Yeah.
Yeah. So we've talked about what we do. Can we talk a little bit about the benefits that lived experience can bring to the people that we're supporting?
Yeah, so I think that's a really important point, because obviously there's no point us doing our job if it doesn't benefit the people who we're working with. Some of the benefits I see working in the complex emotional needs service is, like I mentioned before, we work with people who are in extreme levels of distress and potentially feeling quite suicidal and involving themselves in self-injury and things like that. And having somebody to talk to who has been in a similar situation to them and experienced those similar extreme emotions, but who quite evidently has come through that because they're able to sit there and have a conversation in a kind of professional sense with the patient, is really useful, because it gives the client the hope that things can improve for them. Because if it's improved for this person, I always say to somebody, I'm not, some freak of nature who's been the only person to recover from my mental illness. But there's loads of people out there like me. And if we can recover, then so can you. And that can make a huge difference to people when they're feeling at that really low point, just having that kind of, that feeling that things can get better. So I think that's probably the main benefit we have. I don't know. How do you feel?
So I was just thinking about when a patient's being asked to do something that they're not entirely comfortable with. It can be really useful to be able to talk them through what that process might look like. So, for example, someone being asked to take lorazepam for the first time, and they're really worried, are they going to be too sleepy? Are they going to forget what's happening? Are they going to do something embarrassing? To be able to sit and explore some of those concerns in a really kind of slow and gentle way, but then also to talk about maybe some of the benefits that I've experienced from taking that medication. And to acknowledge that I wasn't particularly keen to try something new. Let's just, let's take it a step back. You're really distressed. We'd really like to bring that distress level down a little bit, and this might help to do that. Sometimes people will listen to that from someone who's done it in a much more open and kind of willing way than somebody telling them, I need you to take this because it's going to calm you down.
Absolutely.
So it doesn't always work, but it's another option that can be used if somebody's really struggling, to say I've done it and it was okay. I also find things with coping strategies or grounding techniques. People are like, I've tried them, I hate them, I don't want to do them. To then be able to say it's absolutely fine if you hate the ones you've tried. I really hate this one, but let's try and talk through some of the other options. And I think somebody saying, do you know what, I don't like mindfulness, is quite refreshing for someone being supported in a stressful environment. They're like, oh, okay. I said, I don't like mindfulness, but I really find kind of square breathing. That can be really calming. And then it's just acknowledging that not everything works for everybody, and giving people the confidence to say, well, I've tried it, it didn't work, I'll try something different.
Definitely. I think also we have that potential to work in an indirect way to benefit the clients who we work with. So by working with the professionals around us and the clinicians, and like doing things like working on that language and the stigma and the kind of putting the client's view across in these multidisciplinary meetings that we keep talking about is really important, because that benefits the client themselves, because they get their view put across in these meetings, which they might not be able to attend themselves. And then that can have a direct impact on the care that they then receive as a result of that. So
I also find myself asking, why are we doing this?
Yeah.
And if you challenge the group, the MDT or whoever's discussing, sometimes it helps to people to think in a different way and not just do what we always do. So that can be quite refreshing as well.
Definitely.
I brought along with me a couple of feedback statements from people that have had support in the mental health liaison team.
Oh, fantastic.
So I thought it might be useful to hear it in the person's own words rather than us telling you. So one person said, they were there to offer support to me when I found days tough. They helped to explain how everything worked regarding the various healthcare teams and meetings, so that I was less overwhelmed and understood what was happening and the decisions to be made. So I think we've become almost experts in the system. We know how things work, and it's useful to be able to bridge the gap between clinicians who've been doing it so long they almost forget that other people don't know how this works.
Yeah.
And being able to take a step back.
Yeah.
And help people to understand what's happening next. Why did that happen? Another person said, I felt heard, supported and understood. I don't feel heard by a lot of staff, but this time I did. It's an understanding that only someone who has experience can provide.
Oh, that's lovely.
That made me quite emotional when I read that one. But I remember the person, and I think it was about not telling them what to do, but just being with them and listening. And that's something that we have time to do that, somebody who's incredibly busy in the emergency department just can't do. And giving someone that time can give them the space to work out what's going on and what they want to happen next.
Yeah.
So
that's really good.
Yeah. I suppose what leads on from that is, what's the best part of your job?
Oh, yeah, that's the question, isn't it? Everything about my job is the best part of my job. No, I really enjoy every aspect of my job. But for me, the best part is the peer support sessions. I really enjoy working one-to-one with people and seeing them develop over the time that I work with them, because for some of my clients, I work with them for a kind of long period of time, and I can see them sort of grow in confidence, and their self-esteem increases, and their kind of their joy for life increases, and they often say to me that they're moving from a state of not functioning and just existing to a state of actually living. And I think seeing that progress is probably the best part of my job. Yeah. How about you?
I don't get that, because my contact with people is generally fairly short.
So short term, yeah.
I think I really enjoy being able to build a rapport really rapidly, and to see somebody going from incredibly tense and unable to engage with people around them to just relaxing enough to be able to start to have a meaningful conversation. One of the phrases that people often say is, oh my goodness, you just get it.
Yes.
And it makes it so much easier to build that rapport and to build a bond with the patient if they understand that you have a shared experience. It sort of takes down a whole load of walls that other people would have to break through.
Yeah.
And it's that realisation when somebody understands that you are where I am and you're doing okay.
Yeah.
And there is a possibility that I'm going to make that journey too.
Absolutely.
And this is possibly worth fighting for. And just seeing that change in somebody is phenomenal. It's amazing.
Yeah, I completely agree. Yeah, it's such a great job.
So, Jim, thank you for joining us.
My pleasure.
Do you want to just start by introducing yourself?
Yeah, certainly. So my name's Jim Welch. I'm the Clinical and Operational Lead for Mental Health Liaison Services, and I'm really excited to be able to develop the lived experience workforce. So thank you for inviting me today.
No problem. So I thought we might just start by talking about how our colleagues in the Acute Trust can make best use of the lived experience workforce. From my perspective, it's understanding what we do is always going to be the first step. So if you've watched this video and you want to know a little bit more, we're very happy to come and explain what I do. I think if someone is seeing a patient who they think might benefit from lived experience support, it would be a case of just asking, and we will be able to say, yes, that's something we can help with, or no, it's not. I'm also really happy for staff to ask me questions. It could be questions about language that they want to use or an approach they want to take. I can give you not the clinical professional response, but more the kind of from lived experience that might not work, or yes, that sounds like a really great idea. So I'm always happy.
Element.
Yeah, the human element. I'm always happy to be used as a sounding board. And as you probably know, I'm quite happy to challenge if I think maybe we're missing a trick, if there's something different that we could do to support a patient. One of the key limitations of lived experience is that any kind of support or guidance I give would be from my own lived experience. But I can also bring in then what I've learned whilst I've been supporting other people. So I've kind of built up an understanding of what works well for people and what doesn't. And I'm very happy to share that with staff in ED or staff on the wards.
I think that's where the added value comes from, because as a clinician, I'll see someone perhaps as a cluster of symptoms, as a clinical problem to be unpicked and solved.
Yeah.
What I don't necessarily see is how that feels for the person who's experiencing it. And I think the added value that lived experience brings is you have that human understanding of recovery and of how it feels to have been unwell.
Yeah. Yeah, and I think that can be really useful both for staff and for the individual. And I was saying to Jo earlier, sometimes I feel a bit like a bridge, bridging between the patient and the clinical staff, because I have privileged insight into both areas now.
Yeah.
So from your perspective, Jim, what does having lived experience staff within the team, what benefit does that bring to your team?
I think at its most basic, it brings a depth and a quality of that human experience of having gone through an illness process, from living a functional integrated life to having been unwell to going back to living a functional integrated life, and being able to offer that hope to someone who perhaps has lost their hope. Being able to talk to a clinical team, such as my nurses, social workers, doctors, not as another clinician, but as a person who has gone through a process that's fundamentally changed them, and has given them a depth of insight and awareness that we potentially lack. And I think the medical model, the nursing model, sees people as patients or as problems to be unpicked, whereas lived experience says, I'm not a problem to be unpicked. I'm me, and I can bring me to the equation. And it's something I've wanted for 10, 12 years.
Yep.
Been really keen to have the voice of people who understand mental health at a depth that I don't, and I don't think many of my team do. So you bring a wealth of of quality, depth, breadth of understanding that clinicians simply don't have, or don't have time to reflect on, to be able to access from their own experience.
I was very pleasantly surprised, I think on my second day, to be asked by a consultant psychiatrist what I thought of a situation. I was a little bit shocked. It took me a while to gather my thoughts, but I was really impressed that they wanted to know what I thought. so that they could factor that into how they supported the individual. It was really refreshing, really positive.
Because mental health isn't about the professional qualification, it isn't about the university. Actually, it's about the meaning in somebody's life. And that's what I really wanted to hear and for the team to be able to benefit from. And I think when you only see unwell people, you perhaps lose the potential or lose sight of the potential for wellness for somebody to regain their wellness. And that's really important.
I think it's actually particularly difficult for emergency department staff and for staff on the wards who see someone very unwell and they're still very or fairly unwell when they leave. So it must be almost refreshing and reassuring for them to see that people do leave, get better and carry on with their life.
Yeah, completely. And we look at, trauma-informed. There's another video in this series that talks about trauma-informed care and how emergency department and other staff can be traumatised by their experience of providing care to people who are extremely unwell. Actually, to then meet somebody who has been unwell and has recovered and is now able to use that experience is really powerful to help them to process their own trauma.
Yeah. So something I've been asked is, do colleagues have to be careful about what they ask a lived experience practitioner or a peer support worker to do? From a manager's perspective, what's your thinking on that?
So I think what we've done is we've been quite clear that your intervention is not a clinical one. We're not asking you to provide a nursing or a medical opinion. We're asking you to provide the humanist view of someone's experience and to support them during the recovery process. I see your interventions, lived experience interventions, as being part of a wider system offer, wider team offer. So I don't think being worried about exposing you to something. I think it's more about making sure that everyone has the right support to be able to meet the needs of their role and support the patients under their care as they achieve that recovery. I think there are perhaps issues around risk. So we might perhaps not want to involve you necessarily in the formal assessment of risk, but actually you are a resource within the team to be deployed to someone who might benefit from having a humanist conversation.
Yeah. So from my perspective, when I joined the Trust, I had the benefit of a really comprehensive training package that focused on peer support and lived experience. And part of that was giving us time and space to assess what are we confident doing, what might be distressing, what are we willing to share with someone. And I think having had time to think about that in advance means as an individual I'm aware of what I feel able to do and what I don't feel able to do. So I would be able to communicate that with either one of my colleagues or somebody else in the department to say, actually, that's not something I feel I can contribute to.
Yeah, and you would share what is appropriate for that situation.
Similarly, if a patient asked me for information about my recovery that I wasn't prepared to share, I have a kind of a kind way of saying no. I'm not particularly keen to discuss that, but let's explore why you've asked me that. So I think that particular training course gave me a lot of tools and insight that means so far I've not come across situations that I found particularly distressing or worrying because I've already had a chance to think about it. And I think it's really important to reiterate that just because I have had mental health difficulties in the past doesn't mean that I'm exceptionally vulnerable or need protecting. I'm quite happy to crack on and do what I need to do, but I'm self-aware enough to highlight if something's outside my either my skill set or the boundaries that we as a team have set for my role.
Yeah, very much so. I think that induction is key.
Yeah.
Not only for the individual but also for the team.
Yeah.
Because this has been a development and we've needed to learn a new way of working.
Yeah.
But actually, I think it's gone incredibly well, and really excited to be recruiting our second practitioner in the next few days.
Yes, was just discussing that I've gone through that very lovely period where I'm busy. And now we're getting to the point where there's more than I can do on my own.
Yeah.
And that in itself is really exciting that colleagues are seeing the benefit and asking for me to be involved in the care of different individuals.
Yeah, absolutely.
I was talking with Jo earlier about how we get involved in patient care, how people know about us, how they can request support. Do you want to talk a little bit about how, if the emergency department wants support from a lived experience practitioner, what they would need to do?
Yeah, certainly. I mean, I think it, in many respects, it's as simple as contacting the liaison service, picking up the telephone and saying, I have someone here who I think might benefit from meeting someone who has lived experience. I think as this video perhaps gains traction and more views, people better understand that, picking up the phone, dialing 5490 and saying, could a lived experience practitioner come and support this person to augment and enhance the care that we're offering.
Yeah.
What I'm also quite keen to do is to begin to publicise your role more widely. Well, I think we understand it. I think the patients who've benefited so far understand it. But we have a big piece of work to do in order of raising awareness across the wider organisation. Thousands of staff, working shift patterns who may have heard something but perhaps don't really understand what to do or what value it adds yet.
I think that's quite reflective of the national situation. It's recognised that those who've worked with a lived experience practitioner or a peer support worker have a good understanding of what the role is and are quite happy to request our support. But for other people, it's a little bit kind of, what is it? What do you do? And so I think the most important thing is people just asking. We can tell someone that this is or isn't appropriate, but the more people that ask, the better.
Yes.
In terms of the way I work, I don't work independently, so I would always see a patient at some point with a qualified colleague from within the team. But it can be that I am then the primary contact for somebody going forward if the lived experience component is what they need at that time.
Yeah.
So there's always, for me, the clinical support and the support with assessing risk and making sure that what I'm doing is appropriate. But it can be that, for a patient on the ward, I might be the person they see on a weekly basis, and I escalate to a colleague if I think things are changing or if I need some guidance or support. And that's worked quite well so far.
Very. And I think that the extra offer, so one of the things that I was really struck with the service that we provided was that it ends at the door and there's no extension into the community.
Yeah.
But actually many patients who come to the emergency department will come by ambulance, they'll come following a really traumatic event, they'll leave that behind, it almost stops in time and doesn't start again until they return to the environment they came from.
Yeah.
And for me, I reflected that walking through that door for the first time could be a really frightening experience.
Yep.
And that's where I think that opportunity to ring somebody to say, hi, I'm just ringing you from the team just to say, how's going home been?
Yep.
Is there anything you need? Is the plan still working for you? Is there anything we need to revisit?
Yep.
That's really powerful.
And we've had some quite positive feedback from patients who've said, I went home and you're the first person that's spoken to me since the most traumatic day of my life when I, for instance, tried to end my life.
Yeah.
And to have that human contact, to revisit the plans that were made in the emergency department, make sure the person understood them, and also just talking through barriers. It can be they've been asked to phone their GP surgery, but they're really embarrassed by what's happened, so they haven't. But talking to me allows them to just unpack that and realise that actually it's really important that they do contact their GP surgery, and they know, they might ask me to ring them in a couple of weeks just to check that they have. And it's not a me keeping an eye on them kind of thing. It's just they know that without that kind of human contact, they might not take that really important step.
Yeah.
So it's good to be able to provide a much more wraparound, holistic approach, and that's very much in line with kind of guidelines, with the NICE guidelines, and just with a human approach of let's be there for you.
Yeah. So it's let's put this back into your life. as you learn to understand your life as it now is, but let's give you that support to be able to explore it in a way that's meaningful and valuable for you as a person.
Yeah.
And being able to do that in a non-clinical, not like a person under a microscope, but a person you walk alongside,
Yeah.
is really valuable.
Yeah. Anything else that you feel ward or ED staff would benefit from knowing about lived experience?
So I guess my key ask would not to be scared. Not to see the person in front of you as vulnerable or necessarily fragile.
Yep.
But to understand that lived experience practitioners bring an opportunity for us to truly deliver holistic care
Yep.
at a meaningful level for a person who may simply need a connection with hope and an understanding that as bleak as things can be, the future is still possible.
Yep.
And as a service lead, I'm really keen we take advantage of that and we promote that for as many people as possible. And I hope as years go on, we recruit many, many more lived experience practitioners across the directorates and across the hospitals. So everyone, I reflect that no one understands perhaps cancer as well as someone who has had cancer.
Mm-hmm.
No one understands diabetes as well as a diabetic.
Mm-hmm.
And yet, what opportunities do we have for connecting people at a one-to-one level? Groups are great, telephones are great,
Yep.
online forums are great, but actually there is a significant value in one-to-one human interaction from someone who truly understands. And that, I think, is the direction that healthcare needs to take.
That's really good to hear. So I suppose ring 5490
5490.
if you feel there is someone that would benefit from lived experience support from the mental health liaison team.
Yeah. If you think that there's an opportunity for a human conversation to contribute to the care of your patient, the person in your care, pick up the phone, dial us.
Thank you. And I'd just like to thank Jo as well
Absolutely.
for joining us earlier.
Thank you. Yeah, really grateful to have Jo come and talk to us as well, so thank you.